welcome indeed to the Melbourne Festival of Ideas here at the University of Melbourne. It's day 3 of 5, very action-packed, heady days. Who's been here for part of the week? Oh, ripper. Fantastic. I hope you've been having a great time. And today will be no different. My name is Natasha Mitchell. I'm from ABC Radio National. I host our daily program called Life Matters. And of course, well before this gathering of ideas and debate, the traditional owners of the land here, the Wurundjeri people of the Kulin Nations, have gathered here for many centuries before us, doing the very same, debating and engaging with ideas, and we acknowledge their elders of every generation, past, present and future, as we gather here today. And please let me encourage you to spend some time at the Bunjil Nest Project. They want you to share your messages of hope for the future, and it's just out there in the main area of the festival. So take some time to do that. We'd also, on behalf of the festival, like to acknowledge the sponsors. You can't do these things without sponsors. So let's thank Vic Health, let's thank the Club of Melbourne Ambassador Program, and of course the wonderful City of Melbourne. Now, who's a tweeter? So get busy. The hashtag is I think it's UOMFOI. So University of Melbourne Festival of Ideas, UOMFOI. You can tweet comments, but we'd love you to tweet questions, because we have the head of the University of Melbourne Debating Society, who's going to be our tweet curator when it comes to that, and his name is Liam Gage Brown. Thank you, Liam, indeed. We've got a great topic today, medicalising normality, and we've also got a great exercise that we'd like you to participate in. It's not every day that you get to collectively design a disease. And that's what we're going to get you to do today. We're going to get you to interact with each other to come up with a disease. We want you to define that disease. And then we're going to get you to develop a marketing strategy for that disease as well. It'll all become clear as the session goes along, and you'll probably get some ideas. You can be fanciful, you can be very earnest about it, you can be fantastical. It's a chance to get creative with the possibilities, because we're going to be talking about the question of whether there might be too much medicine going on. Are we turning to medicine too often to fix society's ills and our own afflictions? That's the kind of provocation we have before us today. Are we increasingly defining difficult behaviours or difficult experiences as diseases or medical conditions? And what is legitimately a disorder and what isn't? And who gets to say what the specifications are, the definitions of disease are? Is obesity a chronic disease, for example? What about addiction? What about low libido, sexual desire? What about premenstrual tension? What if someone called that a disorder? So we've got 3 fantastic speakers here today to each offer their perspective from their field of endeavour. I guess some of the themes that will come up are, is a disease something that has a biological pathology attached to it, or is there a social story going on here as well? And why does this all matter anyway? If we can get treatments for difficult experiences that we're having, well, isn't that a good thing? So, 3 fantastic speakers, and I want to start by introducing from Adelaide child psychiatrist Professor John Jureidini. He's going to be speaking about children and behaviour. We also are going to be joined by journalist, author and researcher, a very well-known investigative health journalist, Ray Moynihan. He's going to be turning his attention, as no doubt he does, to sex and other topics. And we also have public relations consultant, a health specialist, Martin Palin, who will be asking what is a real disease, and he's going to be advocating for disease awareness. So let's introduce John Jureidini. He's a child psychiatrist at the Women and Children's Hospital in Adelaide. He's a professor in the disciplines of psychiatry and paediatrics at the University of Adelaide. And amongst other many interests, he's a spokesperson for an organisation you may have heard of. It's called Healthy Skepticism, and they're focused on countering what John describes as misleading drug promotion. Let's give him a big hearty welcome.
Thank you. We'll have lots of opportunity to talk about the role of doctors and the pharmaceutical industry in disease mongering. I want to talk about how fear of children's pain contributes to the medicalisation of children's distress. Now, I want to talk about the role of parents in that, and when I use the term parents, I'm not just referring to biological parents or caregivers, but to all of us in our parental roles, whether it's as therapists, teachers, etc. And when I'm talking about children, I'm encompassing anybody who's kind of emotionally dependent on a parent of some sort, which is possibly most of us. I think that we parents disrespect our children's ordinary, healthy, but potentially painful and distressing feelings of anger, shame, fear, sadness, grief, disappointment, and that we behave as though there's an entitlement or an expectation of happiness. And if our young people are unhappy, we think that there must be some obstacle that needs to be removed that will ensure their happiness. True happiness is only a diet or a frock or a pill away from us, and if we can just find the right match, we will be made to feel happy. And our tendency as a society is to label and intervene rather than sit with these uncomfortable feelings. And if we can't fix things in order to ensure happiness, then second best is to ensure some level of numbness, some analgesia from some drug or activity that will take away the pain. The contrary position I want to put is that we should be much more trusting of children's ability to deal with strong and uncomfortable feelings, that we should be much more respectful of the amount of time and space that's required in order to do that, and that we as parents have to learn to tolerate and manage our own anxiety that's generated by virtue of respecting the time and difficulty that dealing with strong feelings presents. Because the distress that young people experience is a big deal. And there's the notion of adolescent turmoil and the idea that we should not dismiss adolescent suffering as just adolescent turmoil. Well, we need to get rid of the just, certainly, but adolescent turmoil is a big thing. And the fact that somebody is distraught doesn't mean that they're sick. And this can take us to the edge of breakdown, and parents will say, I think my child's having a breakdown. But the breakdown might be a developmental breakdown. That is, it might be the kind of event in a person's life that they come out of better than they went into it. And I think we underrate the number of times that adolescents are forced to go through a very difficult period of time in order to come out the other side as mature, functioning adults. Whether it's confronting the disappointment of some achievement they're never going to have, or letting themselves down, or letting their parents down, or some grief or loss that they've not had to come to terms with before but are struggling with now that they're more cognitively mature. These are big things, and they can lead to a kind of madness. But it's most often an ordinary madness that needs to be supported and contained, not to be treated and diagnosed. It's also potentially fatal. You know, a parent might say to me, she's cutting herself, will she kill herself? Or he's smoking dope every night and getting stoned, will he end up being a junkie? And how could I live with myself if I didn't do something about that, something to prevent it? I think that one of the problems is that we get confused between the need to take things seriously, which we do, and the desire to take things away, which we might not be able to, and even if we can, it might not be in people's best interest for that to happen. So you can take things seriously without taking them away. Now, confronted with a young person who is distressed, we need to make sure that they're adequately protected from dangers that we can take away, and we need to make sure that they're adequately informed about what their choices are, and we need to confront them when we think they're making bad choices. But you can see the problems that might occur when you go too far in either of those areas. If we overprotect, if we stray from informing into berating, if we confront in a way that's humiliating and disempowering, then these apparently well-meaning activities will do more harm than good. Our children are ugly in their behaviour. They behave in ugly ways that we don't like. And one of the things that I come across that I think is really toxic is when parents say to me, I won't reward bad behaviour. Now, if you think of a distressed infant behaving badly, we don't say, I won't reward that bad behaviour. Actually, some people do, but that's another topic. When I say let the children cry, I'm not talking about controlled crying. So in the same way, when young people behave in a way that's objectionable, that's not an invitation to us to manage their behaviour. It's an invitation to us to try to understand their behaviour. What are they telling us? An angry, hostile adolescent is usually protesting about something in their life. They might not know what it is, and they might do it in a very clumsy and unattractive way. Our task is not to manage that behaviour and suppress it, but to understand it and give it meaning. That doesn't mean we should let them walk all over us, but it doesn't also mean that we should deprive them of our attention because we think we mustn't reward bad behaviour. It's really an invitation to intimacy. And if that invitation to intimacy is resisted, then it can have fatal consequences. And I've recently been involved in reviewing a coroner's case where I think that's exactly what happened. So we're faced with this notion that what our young people are doing might be filling us with fear. And we feel powerless to do anything about that. And that makes us distressed. We've got to face off that fear and stand up to it. We've got to trust that our young people are going to be able to get through this process. Sometimes it looks like they're not trying. Kids are much more like hares than tortoises. Their trying comes in bursts and then they go through periods when they don't try. But if we overall come to the conclusion that they're not succeeding because they're not trying hard enough, and we berate them to try harder, we often will add to their sense of failure because I've been trying really hard and not succeeding, and just telling them to try harder will be experienced as persecuting for them. We need to make time so that they can sit with the feelings and the experiences, that they can have completed experiences. And our society very systematically denies children completed experiences. It denies them the opportunity to get bored. They've always got a Facebook conversation or something, a screen that they can go to that prevents the onset of boredom. Now, boredom is a very developmentally important experience because those of you who are old enough to have had a boring childhood will probably remember that it was in times of intense boredom that you generated some of your best ideas, activities, relationships, because you were forced to sit with that boredom at the beginning of a long summer holiday where all your mates were away. And the first day was terrible, but then you discovered something that you wanted to do and explore, and that evolved into some lifelong passion. The distress that young people feel, the disappointment that they feel, is not something that goes away in a couple of days. And, all of the psychiatric textbooks teach us that if somebody suffers for more than 20 minutes, then we have to worry about them, and that's diagnosable. When seriously bad things happen in your life, it takes weeks, months, years to resolve them. And we have to give young people that amount of space to be able to work through and deal with those issues. And we have to somehow try to find a way as a society to resurrect reverie, times when people aren't doing anything except thinking and letting things pass through their mind in a way that generates healing and generates new ideas and creativity. And underpinning all of that is our need as parents to be able to tolerate anxiety. And I want to draw a distinction between sympathy and empathy. So if I see a distressed young person, my sympathetic response is to get upset myself. And then I want to do something about the fact that I'm upset. And the fact that I'm upset might rekindle all kinds of things that I'm disappointed about in my life, and I want that feeling to go away. So if I act out of sympathy, I'll want to suppress the young person's feelings in order to make me feel better. If I act out of empathy, I'll be able to put myself into somebody else's shoes. And that can be a really easy thing to do, something that comes naturally and is very cheap. My own example of that would be walking into Woomera Detention Centre and seeing a lot of little kids locked up behind razor wire who look just like my kids. There was no cost to me in developing empathy for those little refugees and their families. But somebody who hasn't had that experience, who wants to think through the issues to do with refugees, would need to actually go through a quite expensive cognitive process to put themselves in the position of the person and to identify with them and try and work out what it's like from their point of view. So as parents, that's what we have to do with our children. When their behaviour is unattractive and difficult to identify with, we have to work hard at taking that empathic stance from which we can see what's in their best interests and not act out of trying to deal with our own anxiety and do what's most comfortable for ourselves. When you sign on as a parent, you're signing on for sleepless nights, not just the sleepless nights associated with a restless toddler, but the sleepless nights of lying awake wondering what your adolescent is up to, whether they're home or somewhere else. And if you're not doing that as a parent, then you're exporting too much of your anxiety to other people and you're not being the kind of parent that our children need us to be. So what we need to do as parents is to trust kids and trust their ability to deal with, experience, survive feelings. We need to make space and protect the space for them to do that. We need to manage our anxiety, and we need to give them the gift of being good at feelings, of being able to make sense of uncomfortable but healthy feelings like sadness and fear and shame, rather than trying to give them the gift of happiness, which is shallow and evaporates in the face of adversity. Thank you.
Wow. Who's a parent? Who's a kid? Seemingly relevant to all of us, I suspect. Thank you very much, Professor John Giardini. And a reminder, if you have questions and you'd like to tweet them, you can tweet them and use the hashtag UOMFOI. So if anything's come to mind that you'd like us to put to John later in the conversation, please do. Thank you. Well, now let's come to Ray Moynihan. Ray is a multi-award-winning Australian researcher, investigative health journalist, a doco maker and author. He's a columnist with the British Medical Journal. He's also doing his PhD looking into what he describes is the modern epidemic of overdiagnosis. And you might disagree with him, and I'd like to hear from you today. I want to hear your disagreements with what you're hearing, and perhaps your affirmations as well. He's the author of Too Much Medicine, Selling Sickness and Sex, Lies and Pharmaceuticals, and he was involved also in organising what was the inaugural conference some years back on disease mongering here in Australia. And here he is. Let's give him a big welcome.
Thanks, Natasha. What Natasha didn't mention was that I'm also a sufferer of motivational deficiency disorder, which affects 1 in 5 people. Most of them don't know they have it. I can see there's a few people up the back who may be candidates. Now, some of you won't have heard much about this, so just to give you a sense of some of the symptoms, they can include not being able to get off the beach, lying on the beach for many hours at a time, feelings of being trapped on the couch. I don't know how many people have had that experience of being trapped on the couch. And of course, it can be mild or severe. In its severe forms, you can lose your relationship, you can lose your job, and you end up with a very messy house. Now, what I'd like to do is to tell you that the good news is that I was diagnosed early by Professor Lethargos, who discovered the condition just a few years ago.
The condition varies from very mild. There are people who perhaps notice a slight reluctance to get out of bed on Monday morning at the mild end of the spectrum, through to the most severe disease, which is potentially fatal. These are people who find themselves at times in an acute attack, unmotivated to breathe, and these people will die.
But of course, the good news is that there is Strival, and I really don't go anywhere in the world without this now. That's true, and if anyone would like some later, that's great. My mother's a bit concerned because I told her that I didn't actually know what was in there. But as I say, the good news is now this drug, Strival, its generic name is Indolabant, and Indolabant showed incredible promise in the early clinical trials that were funded by a company called Health Tech. And if we could just have the second video.
The effectiveness that we've seen in the trials has at times been quite remarkable. I had recently the wife of one of our participants ring me, and she was in tears. She was in tears at the extraordinary change in the behaviour of her husband. She reported that after the use of Indolabant, her husband had mowed the lawn, repaired the gutters, and then paid an electricity bill, all in the 1 week. This was such an extraordinary change in his behaviour that she was overcome.
So as I say, the Strival is available for anyone who wants it. Now of course, there is a serious element here, and there's absolutely no sense that this analysis, this discussion is about delegitimising genuine illness and genuine pathology. On the contrary, the resources and the attention and the care and the media headlines and the scientific research that are wasted on mild problems or people at low risk takes resources from treating and preventing genuine illness. This is a crisis for medicine. We've heard over the last few days about the problem of excess, and I think that's a theme running through this conference, that our love affair with excess is making our habits unsustainable. We know that about the planet. I don't think what many of us realise, that medicine itself is part of the problem. Medical excess is out of control, not just in terms of the numbers of tests and diagnoses and drugs and operations, but the labels themselves. We are seeing a widening of the boundaries of medical illness across many conditions. Now, this is not a negative message to go home and fret about. This is a very positive message, because it may well be that many of the medical labels that you accept for yourselves or your loved ones are not really necessary. And the last book I wrote was called Sex, Lies and Pharmaceuticals, and it was if I do say so myself, a meticulous documentation of the creation of a new condition. Over the last 15 years, there's been a coordinated attempt to create a new condition called female sexual dysfunction. Before I go into that, I should just quickly do this test. Getting back to this, have you ever felt lazy? This is just to test how many people in this room have motivational deficiency disorder. Have you ever felt lazy? Do you have a family history of laziness? Have you ever considered hiring someone? And are you breathing? Now, if you answered yes to any of those questions, you really should see your doctor. Sorry, that was out of order. I apologise. This is a serious statistic published in the Journal of the American Medical Association in 1999. JAMA, as any researcher in this audience would know, is one of the most highest impact medical journals on the planet. We would all wet ourselves if we had a paper accepted there. A paper was, in fact, presented that suggested 1 in 2 women have it. Now, this was the questionnaire that figure was based on. In the past year, was there a period of a few months when you lacked interest in sex, had trouble getting aroused, felt anxious about your performance, didn't find sex pleasurable, and the next one I really like, came to climax too quickly, experienced pain, or were unable to achieve orgasm. Now, if a woman answered yes to just one of those questions, she was classified for the purpose of that survey, and this paper, by the way, the JAMA paper, has been cited more than 1,000 times. This is not an irrelevant piece of research. This is junk science, and it's an extreme example of a much broader problem. So this is an example, as I say, it's an extreme example of a much broader problem. 1 in 2 women, according to that article, were classified as having FSD. Key meetings where the condition was being defined in the 1990s were funded by the same drug companies that were hoping to develop a big new market for pills. The Pink Viagra, many of you have heard of. 18 of the 19 experts who defined FSD in about 1999-2000 had ties to a total of 22 drug companies. Now, sadly, as we'll see in a moment, this is typical. In 2009, a press release came out claiming one of the disorders of female sexual dysfunction, which is called hypoactive sexual desire disorder, essentially low libido, that 1 in 10 women suffer from this condition, and that there was a 5-item questionnaire that could be used to diagnose the condition with high accuracy in a few minutes. This is a press release from Boehringer Ingelheim, one of the world's reputable drug companies. They were involved in helping develop this. And this is all documented. So sadly, this is a very egregious example of a much wider problem. In a few minutes, a woman could walk into a doctor's surgery and walk out with a label that potentially could affect her life forever. Many disease definitions are expanding. We are widening definitions. We are reclassifying normal people as sick. And in fact, I just published a paper that looked at 14 common conditions. And we looked at what's happening in those 14 common conditions, whether it's cholesterol, diabetes, asthma, high blood pressure, Alzheimer's. And we looked specifically at the panels of experts that define those conditions, and we looked at what they are doing when they define, when they meet and discuss these definitions. We found that they're creating more pre-diseases. We have pre-hypertension now, pre-diabetes, pre-dementia is the latest one. Thresholds are lowered. What used to be high blood pressure is no longer. High blood pressure, the definitions are getting lower, the thresholds are getting lower. The same with cholesterol, the same with diabetes. We are diagnosing things earlier. When we looked at the conflicts of interest of those expert panel members that were widening definitions, 75% of those experts had financial ties to drug companies. Each expert, on average, had ties to 7 drug companies each. Are these really the people that we want to be defining whether we're sick or whether we're not? Are these the people we want drawing the line between normal and abnormal? And many of us think, some of us think, that they are not the right people. These experts have tremendous expertise in their specialty area, but are they the ones to decide who's sick and who's not? I'm probably going to finish a little bit early because I want to save time for this very exciting project in the middle of this session where we're going to create a new disease and we're going to launch it to the world, and we're lucky enough to have one of Australia's greatest healthcare public relations people here, Martin Palin, and he's going to help us raise awareness about that new condition. But I do want to conclude by saying that we are medicalising more and more normal life. Soon no one will be well. We're wasting resources that are better spent treating and preventing genuine illness. We need new panels of experts to decide what's normal and what's disease. Now, this is not something we can do here today, but rest assured, some of us are working hard on this. And my supervisor, Paul Glasziou, one of the world's most respected evidence-based researchers and clinicians, is organising a conference as we speak for next year to try and get some new rules about how we draw the line between normal and abnormal. And those panels should be free of conflicts of interest, both financial and intellectual. They should be much more broadly representative. We don't want diabetes specialists dominating the panel that decides what diabetes is. We want some of you there. We want health economists there, consumer representatives, people who are interested in the social determinants of health. Currently, the specialists tend to dominate the definitions in their own area, and there's a clear conflict of interest there. And we want these panels to rigorously examine the downsides of widening the boundaries as well as the upsides. And of course, I haven't mentioned any upsides, but there are clear upsides. Some people, many people, benefit greatly from a medical label and medical treatment, but some people at the milder end do not, just as we've heard from John. So that's my proposition. Thank you very much.
Thank you, Ray Moynihan. And that proposition, that's relevant. If you've been here throughout the week, you'll know about this. If you haven't, at the end of the session, after we've also generated, marketed and launched a new disease, you'll also get to vote on propositions, which all goes into summing up the whole project here for the festival throughout the week. I was curious, though, that you kept referring to this sort of strange new species I haven't heard of, normal people. Who are they? Now I'd like to introduce, I think, a rather brave soul, actually, because I think Martin's colleagues often go, why are you prepared to be part of these dialogues? And so I'm very grateful that Martin is with us today. Martin Palin is the Managing Director of Palin Communications, a leading Australian PR agency which helps healthcare companies launch new products, raise awareness about specific diseases. Martin previously worked on the Quit anti-smoking campaign in New South Wales. He's also worked as a PR campaign advisor to a variety of medical companies across Australia. And he actually also runs an online course in Australia, I think it's the only one of its kind, focused on medical public relations. It's a certificate in healthcare PR, and it might be something you're interested in doing. Let's give him a big welcome. Thanks.
Thank you, Natasha, and many thanks to the organisers for inviting me to speak and for helping with my accommodation and travel down to Melbourne. I today want to make a few points in defence of disease awareness and thereby hopefully provide a bit of balance to some of what you've heard from Ray today. I must say, as a health promotion guy, it saddens me sometimes that somehow disease awareness has become such a kind of dirty and unfavourable phrase. You know, it used to be a really noble enterprise done for good public health reasons, you know, alerting Australians to diseases and letting them know what they can do to avoid them. And now, as we've seen from presentations like Ray's, it's the subject of derision and ridicule. You know, it used to be a very noble enterprise. But look, maybe I can put some context around that for you today, because I want to bring some attention to the benefits of disease awareness and the good things that come from intervening earlier in diseases. Because much of the critical public discussion around the risks of overdiagnosis downplay the benefits of early detection. So, you know, Ray made reference there to the paper that he just recently had published, you know, a study into the role that paid advisors play in making decisions about the definition of disease around high blood pressure and high cholesterol. And there was a whole range of media interest in that, in Fairfax websites and The Age and the Sydney Morning Herald. But as so often the case with these kinds of articles, they make no reference at all to the potential benefits of early diagnosis in these conditions. And so to constantly emphasise the risks is to deny that good public health policy and clinical practice is obviously a balancing act. It's a balance between the potential harm of the intervention that might come from identifying an early sign of the condition, perhaps some biomarker or a screening image, versus the potential public health benefits that come from early diagnosis and treatment. And I don't know if Ray mentioned this particular condition today, but we did talk about it a little on radio when we chatted about these subjects with Natasha yesterday on Life Matters, and that was looking at these issues in relation to particularly controversial diseases like ADHD. So let's think about ADHD for a minute. The portrayal of ADHD in the common media, as everyone would know, is incredibly negative. The framing is typically around, campaigners who want to save children from being overdiagnosed and medicated, versus the parents who seem determined to drug their own children. So, let's look at a couple of questions around that. So first of all, do families and children get benefits from being treated for ADHD? It strikes me that the overwhelming answer to that question is yes. I've helped ADHD patient groups and manufacturers, for that matter, with their PR, and the frustration that they feel at the public portrayal of the disease is really palpable. They ask questions like, why can't there be good stories told? Many of them are families whose life has been made more pleasant, more livable and more bearable by accurate diagnosis and effective medical treatment of their ADHD. So second, and perhaps a related question, is this question of diagnosis and medication. Is ADHD overdiagnosed in Australian children? And are there more children on medication than there should be? So, we're bombarded with stories from the evening tabloid current affairs programs and the News Limited papers about drugged up kids and an explosion in the writing of scripts for ADHD. So is it overdiagnosed? I think there's some pretty strong evidence to suggest that the answer to that is no. Let's assume, based on the National Health and Medical Research Council guidance, that the prevalence for Australian children for ADHD is around 5%. There is actually some evidence that it may even be slightly higher than that. And then let's look at the data from just one state, Western Australia as an example, where some people claim it has a high level of prescribing in Australia. So the prevalence figure is 5%, and the actual stimulant prescribing level in Western Australia is just over 1%. I should have seen if that would. And so it's even possible, based on the evidence, to suggest that ADHD is being a little underdiagnosed in Australia and the medications are being a bit underused. And I only make this point because you wouldn't know that if you watch Today Tonight and you read the Herald Sun or the West Australian, because the stories there are all about ADHD epidemics and a lost generation of drugged up kids. And so what I'm trying to suggest is that it's helpful in the debate if we extract the morality and the emotion out of that discussion and think about what we need to be doing for children from a clinical perspective. You guys may have even seen the recent story in The Age and elsewhere about the number of overdoses that result from prescription medications. And I heard some of the Conservative commentators there on the breakfast TV programs the following morning saying that it was a result of doctors being too ready to prescribe medicines to children for ADHD, despite there being no evidence that ADHD medicines were even implicated. So, we're on a short timeline here, and time forbids a full treatment of other diseases like depression, but the conclusions are similar. Early detection and diagnosis is not about creating an epidemic in depression or making more money for the drug companies or helping the psychiatrists to get rich. It's clearly about effective early management. Think about obesity. I think obesity and overweight in Australia is a really interesting example, because the question there is it a good thing or a bad thing to medicalise obesity? Severe obesity, morbid obesity. So you've got this question about whether obesity should be a medical issue. Perhaps obesity should be classified as a chronic disease, and that might at least encourage obese people to talk to healthcare professionals about the issue, either talk to their GP or their pharmacist. And so you can see what I'm offering here is a balance to the kinds of arguments that Ray and others are putting, that it's actually pretty complicated. It's a pretty complicated balancing act, because in the same way that there are clearly clinical and public health and community health benefits in early detection and diagnosis, there may also be benefits in medicalising some conditions and some diseases that we don't normally think of as needing to be medicalised. And with evidence around the enormous benefits that some very obese people get from weight loss surgery in terms of reduced diabetes and a reduced whole range of comorbidities associated with being very overweight, that's a legitimate question to ask. Are there benefits associated with medicalising a condition like obesity and thinking of it as a chronic disease? So every alleged risk associated with what the naysayers like Ray call disease mongering, medicalisation or overdiagnosis carry the prospect of tantalising benefits in the form of reduced disease, healthier lifestyles, more time with loved ones and longer lives. So the next time you see the reference to the risks of overdiagnosis or disease mongering in the popular media, just stop for a minute and reflect on the benefits that result from increased disease awareness, even for relatively controversial diseases like depression and ADHD. And so that was just to colour the points I was making about the way ADHD is covered in the popular media in Australia, and the kinds of headlines and coverage we see predominantly through the News Limited press. But I just want to suggest that, and this is me coming back to this notion of trying to take the morality and the emotion and the striving for ratings by these popular, particularly the TV programs, that I'd be suggesting the media authorities should have increased powers to prosecute cases against media outlets that frame the diagnosis and early treatment of disease in a negative light to stimulate moral panic and indeed to stigmatise the people affected by that disease. So that proposition, I suggest, puts the other side of the argument to the kinds of suggestions that Ray was making, and I hope encourages you guys, when you think this through, to think that there are two sides to this, that yeah, maybe there are some benefits to early diagnosis and maybe there are some public health benefits in medicalising some things that we wouldn't normally think of as requiring medical treatment. Thanks very much.
Well done, Martin. As a media professional, that's a very provocative proposition, I feel. So I'll look forward to hearing how you vote at the end of the session. So any thoughts, first of all, from each of you about each other's presentations? I mean, maybe John.
This is going to sound churlish, but you know, I think you mentioned about Martin being brave to come and talk in this setting, but I thought what was particularly brave about what you said, Martin, was that you were prepared to argue scientific points as a marketing person that are actually medical psychiatric issues. And I think there were some things there that were just factually wrong. I mean, attention deficit disorder and depression are not diseases. They're syndromes, they're patterns of symptoms that have a wide range of explanations that vary from person to person, don't have specific treatments. The implication that ADHD, there should be some equivalence between the number of kids who meet the diagnostic criteria for ADHD and the number who are being treated with stimulants is just, I mean, even the most rabid ADHD zealot wouldn't say that. It's only a minority of kids who, for those who accept the concept, and I don't, but for those who accept the concept, it's only a small minority of kids who have the disorder who should be treated with the medication.
Can I just ask you, John, do you have children or adolescents in your care that have been diagnosed with ADHD or are treated for it?
Yes.
So how do you navigate that as a clinician?
Well, I mean, I'm forever saying that I've never seen a case of ADHD. I've seen plenty of people who have come to me where the diagnosis has been made by them or somebody else, but thankfully, by the end of the assessment, we've always been able to come up with a better explanation of what's going on than labelling it ADHD. Whether it's something that's like a learning disability or abuse within the family or misplacement within the school system or something, there's always a better explanation. And the same pretty much applies to depression. There are some cases, there are several cases of people who present with depression where we can't come up with a better explanation, but the vast majority of people that I see who come along saying I'm depressed, yes, that's not a bad description of what you're experiencing, but it's not an explanation. And, you know, the more we oversimplify things and fall back on sort of, you know, the notion that we're going to find a simple answer for a complex problem, the worse we'll do as a society.
Martin, your thoughts?
I think John knows what I'm trying to do, and that is to provide a sense of balance and context to the way ADHD is portrayed in the media. I mean, I'm a PR and marketing guy, so I watch the way medical issues and diseases and conditions are dealt with in the media every day. And so if I look at the way ADHD is dealt with in the media, I was today trying to reflect on the sense that that gives of ADHD prevalence and ADHD medication in Australia, and trying to draw attention to some prevalence statistics which come directly from the National Health and Medical Research Council and observations by other psychiatrists, John, who have a view that it's worthwhile trying to put some of those media portrayals into context. I mean, I don't...
You have to accept that the vast majority of representations of drugs and diseases in the media is straight out of drug company press releases. It might be the case that the 7:30 report and the Current Affair make a meal of and an industry out of criticising ADHD, but most new health announcements that come up get swallowed whole by the media.
Let's come to a journalist on the panel, Ray Moynihan.
Well, look, what I think is fascinating is that we do tend to see what we want to see, and I think, you know, I'm as guilty of this as anyone else, and I think Martin and John can look at the same sort of media coverage and see different things in it. And I think what's fascinating to me is that Martin feels as if the media is having a much more critical line on conditions and so on. And in a sense, I think that's probably welcome. Whereas, but also I hear what John's saying, because for years I've looked at the way the media covers medicine, and I've been appalled by the way in which so much of it is promotional. The whole notion of the breakthrough and the wonder drug. But I think that's probably changing a bit.
Well, what about the point, though, that Martin made, where families have a situation where a diagnosis has given them a lot of relief, including their child, for example, of ADHD or perhaps another condition, I'm talking generically here, and it's brought a great sense of relief and kind of calm to help them work through a crisis situation, and they're receiving treatment, and yet there's so much stigma around that very diagnosis that they're suffering because of that stigma alone, even not just because of the illness that, say, a member of the family is experiencing. And that's a problem too, is it not? John?
Well, it is, but I mean, you know, the fact that something makes you feel better doesn't necessarily mean that it's good for you. And labels come with harms and benefits. There's no doubt there's benefits from having labels, but there are always harms as well. And the harms might be a little bit more hidden away and difficult to put your finger on, but in terms of loss of autonomy and stigmatisation. But we can't, you know, what your question suggests that we could solve the problem of stigma by giving everybody a diagnosis, and then we wouldn't feel bad about it.
And that'd be pre-death syndrome, which pretty much is a grab bag for everything, I think.
And I must admit, I'm sorry to disappoint John, but I'm feeling very good because we're having this conversation. It's extraordinary that this debate about the nature of disease, over-medicalisation, has reached festivals like this, and that there is, you know, I've been talking to a few folks around in this area, you know, over the last few days, and this issue really is on the agenda. It's really on people's radar. I hear what you're saying about we don't want to frame this. We don't want to frame the debate in a way that makes people who are genuinely sick feel bad about their label.
Well, though, Martin Palin, is there not a risk of that happening, according to your argument around disease awareness?
Well, I mean, the point I wanted to pick up on was the observation that Ray made about the way the media coverage and the public discussion of diseases really has changed enormously over the last 10 or 15 years. And one interesting example of that is, I think, increased literacy and awareness around cancer screening, for example. So, you know, the previous framing of stories around screening and early diagnosis of breast cancer, of prostate cancer, which was always around, you know, screening's good, more screening the best, early detection's fantastic, where that has become a much more nuanced and more challenging discussion now around the risks and benefits of screening. I mean, that's something that's changed enormously in the last 10 years, and people are starting to understand now that, you know, this notion in prostate cancer that there's a blood test that people put question marks against, encourage the community to think twice before concluding that screening's a good thing, early detection's an easy thing to achieve. It's all now about the benefits of detecting cancers which are genuine versus the risks associated with picking up cancers that otherwise would have caused no problems.
I think we're going to have to hire Martin to do our PR.
John, and I think people will be struck by your call for the need for there to be time and, in some sense, support for parents to develop a literacy around the sort of turmoil that they're experiencing in a home with their children. So what do you think would be the best approach to doing that? Because that's quite tricky. People don't learn how to be parents necessarily at school, do they? So where do they learn? Where do they develop that literacy about what emotional turmoil is and can achieve?
I think we learn as we go along, don't we? And if that's supported, then it can go well. So, I think that, for example, I sometimes find myself enlisting the help of parents to coach their children about feelings. Now, in the process of helping the parents to coach their children, I'm also tacitly, I guess, helping the parents to recognise their own feelings. And so that if you can hold your anxiety in the face of these strong feelings, then it's not just the kid who benefits from that, it's the parent as well. And it kind of becomes a virtuous cycle of the family reaching a better understanding of what feelings are and how they should be dealt with. And these are not stigmatising terms, or they shouldn't be. It should be more comfortable to talk about sadness and anger and fear than it is to talk about depression and anxiety.
Ray?
I was just going to say...
Let's open it to the floor. Absolutely. So we've got roving mics. Please wait until the mic gets to you. Please try and keep it fairly brief and focused as a question. And if you've been tweeting questions, I'll be coming to you via Liam as well. So maybe I'll start with a question from Liam. I may at some point grab a few questions at once and we'll work through them because it just keeps the energy going in the room. In fact, that's what I'll probably do just to get us started, if that's all right. So Liam, who's been tweeting what?
Okay. Is this my phone? So there's a tweet from Twitter user Chase Melb, and they ask, it seems the pharmaceutical company industry drives junk science. How do we separate research and development from corporate intent? From corporate... Intent.
Intent. Okay. Do you want to hold our thought on that one? Another question. Where are the mics? So just be really visible, the mic holders. Fiona Fraser.
Yep. Well, just a comment and then a
Fiona
question.
Stanley. I just called you Fiona Fraser.
You can call me anything,
Yeah.
that's fine. I think we've
Two
got another
amazing
syndrome
women in
here.
public life. Sorry.
Anyway, just an interesting comment that Aboriginal children have very low rates of ADHD and autism, and yet when they did a study in Manitoba, they showed that the white kids who had symptoms like ADHD, these are kids actually in care, they were called ADHD, and black kids in care were called fetal alcohol syndrome. Anyway, it's just another point talking to John, but in fact it has implications, because if you have ADHD, you get a teacher's aide in the school, and if you have fetal alcohol syndrome, you don't. So I just want to make that point, that there are implications about diagnosis to relate to care, which you hinted on. My question to John is that the kind of things you were talking about resonated very strongly with me, about how powerfully positive some of these traumas and anguishes and turmoils that adolescents go through. But how do you scale up your approach to make this, therefore, an effective public, if you like, public health intervention, to actually downplay the fact that these are, in our current society of, as we've seen, the importance to be diagnosed, instant gratification, I don't want pain in my house, etc.
Great. Let's take those two, shall we? So do you want to start with that one, and we'll go to John, and then I'll come back to the first question.
I would think it's a fantastic question. I guess I've only thought ahead so far as trying to get it out to general practice and teachers and counsellors, but getting it to parents, I think, is the really critical step. And I don't have an answer for that, but maybe it's through satire and cinema and those kinds of things that we, I mean, I often say that I learnt most of my psychiatry from growing up in a pub and reading fiction. And I think, in fiction we do, whether it's novels or films or whatever, we do find people grappling with difficult feelings and we watch them do it. And I think that's a really powerful place to learn that. I don't think necessarily you can contrive it.
Any thoughts on the tweet?
Yes, look, in terms of the tweet question, essentially this is part of the problem of the entanglement between the medical profession and the industry. And this problem has many faces, many consequences, and there is, over the last 10 or 15 years, a growing move to try and disentangle. I don't know who to look at when I'm answering the tweet, to disentangle the medical establishment and the pharmaceutical industry. Clearly their drugs are life-saving and ameliorate suffering, and of course they are a critical element of any decent healthcare system. But their influence over medicine is undeniably causing huge problems at a range of levels. So we need, and we are experiencing, a slow disentanglement. At the same time, universities and so on are very keen to get in bed with industry because of all the dollars that flow. So it's a very big, complex problem. However, one of the very positive signs is an increase in transparency. So where we are now compared to 10 years ago, we know a lot more about all the intricate details of who's getting what money.
Let's get a comment from Martin on that.
Thank you.
I was going to say something similar, particularly about transparency. And, Ray and others know that things have changed enormously, and that sometimes the criticisms of the relationship between the pharmaceutical industry and the medical profession and medical groups, in some ways people are occasionally tend to describe that relationship as it was, say, 15 years ago, whereas now, within the Sunshine Act in the USA, by law, the financial ties between pharmaceutical companies and doctors have to be disclosed. There's submissions before Medicines Australia here in Australia through the Transparency Subcommittee that something similar, although self-regulated, not a legislation, will be happening here in the next couple of years. And even as we speak, all of the medical symposia that are sponsored by pharmaceutical companies in Australia is all disclosed on a regular basis. It has to be disclosed via the Medicines Australia website, and happens now in ways that never used to happen.
Just before I come to another question, how do you think that benefits you in your work, that transparency?
I think it just creates a more positive and open environment. When materials are sent out, when media releases go now, there's always, disclosures about Professor Jones as on an advisory committee for a particular company, and people are clearer about the need for that sort of transparency because it puts everything into context.
Hopefully it allows people to ask tough questions too. John, I'll come back to you in a tick if that's all right. Let's grab a few more questions. Thank you at the back.
I've just got a question about, I would like to know the panel's view on the reliability of medical evidence that's used to support certain treatments. Ben Goldacre recently published a book called Bad Pharma, where he suggested that only 50% of trials are published, and that's usually skewed towards the positive findings. And you said if we looked at the negative results from clinical trials, then a lot of drugs would never come onto the market. And that's quite damning sort of evidence that can be believed. And it's a very substantial book. And he was saying that there's a lot of players involved in supporting that situation at the moment, including journal publishers, clinicians, the biotech, pharmaceutical industry, etc. So it's not just one group. There's a whole collusion around the skewing towards the publication of positive results. Has anyone got a view on that situation? Do they support that sort of thesis?
Thank you very much. And I guess that's the nature of scientific publishing too. There's been this emphasis on only publishing the positive. Let's grab a couple more questions if we can while the mics are roving. Thank you. Where is the next one? This one, we'll go there. Thank you.
Thank you for that question. I'd like to support it as someone having taken part in a trial, and it's precisely for the person. I'm not sure that we can get to the public in the way you advanced it today, because when you're the person in a trial, firstly, what you're given is incredibly complex to understand. It does say put your signature. Secondly, there is a whole...
Just talk right into the mic, thanks.
There's a process to go through that is difficult to understand. I think the issue of the good results coming out is supported, in my experience, because the patients, it is a general questionnaire that you get at the end, and it's only seen as a group result. So some of the patients go to lengths to express their experiences, but it's actually not used as any statistics or any of any relevance. So what you get is that bad farming, which is a large, and advocated is a large sample, which could be 100, in my case, 100, 200 or 500 subjects.
Have you got a question?
Yes, the question is, how do you see spreading this understanding, which I did have, to the customer when they don't understand anything about the complexity of the trials, which is becoming more and more complex?
Thank you very much. So that's a very interesting point made by you as a participant in a clinical trial, an important population of people. 2 different trials. Thank you for that. Hold that thought, folks, and we'll come to one more. And, yep, great.
I have a bit of a hunch that a lot of
Just hold that mic right up to your mouth, thanks.
I have a bit of a hunch.
Enjoy the power of amplification.
I feel godlike. I have a bit of a hunch that a lot of people, that we have sort of a culture of measurement where people are always trying to, we want to know who's the best at doing things. People are supposedly promoted in workplaces because they're the best at their tasks. John's not doing it good at school because he didn't get 10 out of 10 as opposed to 9 out of 10. But the reality is, I mean, and this is just drawing on my math and stats knowledge, is that there's going to be variability, not because of the person doing anything wrong, but just because things vary. Things vary a lot. And a lot of people look at numbers and they think, wow, there's this many people out of this many people. But realistically, these fluctuations just happen. It's just white noise. And the tendency for people to believe that data is the actual truth is probably what's motivating a large part of the need to diagnose people.
All right, I'll take that as a Tony Jones moment, and we'll take that as a comment. Can we have just 2 more, and then I'll come to our panel? While we're coming to the next question, if you've got mobile phones, I'd like you to turn them on at this point, because we're going to vote on the proposition shortly. It will just involve texting a code to a number. It's all going to be part of the festival's sort of collation of some of the key ideas that have come out of this whole extravaganza this week. So just get your phones ready, and if they ring, we'll forgive you. Yes, next one, thanks. Where are you? Thanks. Great.
So I actually put my hand up to make a statement, but first I'll respond partly to the other question there. And
keep it fairly tight because we're racing towards the end. Thanks.
I work as a biostatistician in the School of Public Health and Preventive Medicine at Monash, and it's incredibly difficult explaining statistics to lay people. So I think maybe some of that is that it's hard explaining complicated concepts, and the medical students often struggle with describing things.
Yeah.
And also they want to learn the anatomy and the physiology. It's very hard to motivate them to listen to a 1-hour lecture about sampling and uncertainty, even though I do get applause at the end of the lecture.
And your question?
And also making a statement that I saw a tweet about autism through the Twitter feed, and I think that a label has certainly helped me, because I was diagnosed with Asperger's syndrome at the age of 14 when I was in year 9, and that certainly helped me at work and at school and the like, because people do see me as a bit different or a bit weird. So having the label kind of explains why I get stressed, why I sometimes want to curl up into a ball and sleep or whatever. So I think that having the label is useful for me.
I'll just keep the mic because I will just ask one quick question, and that is, you would have watched with much interest that the label has changed and that you've lost your label and that it's been co-opted back into the autistic spectrum in the new diagnostic Bible for psychiatrists. So that would be striking for you, I imagine.
And lots of, I'm in part of the support group, Asperger's Victoria. We've recently changed our name. And I've heard that quite a few of the parents coming along to the support network because their kids have recently got the diagnosis, a lot of their reactions initially before it was moved into the DSM-5 was, thank God it's not autism. That was a reaction that quite a lot of parents felt when they were their child was diagnosed with Asperger's, because I think there's more stigma associated with autism than Asperger's. So I guess those parents now are dealing with the Asperger's being part of autism, not separate to autism, even though it is on the same spectrum.
Thank you very much. That's a really important contribution, so thank you. Let's quickly head back to the panel for your thoughts. So we've had the skewing of positive results. We've had the question of, well, what about if you're participating in clinical trials, making sense of all this stuff? The culture of measurement was more of a comment, but you might have some thoughts. And then also a first-hand encounter with a label that's made a real difference. Thoughts, folks? Put your hand up. Who wants to go first?
Just a quick comment. Thank you for this. And it just raises the great tension whenever we speak about the problem of over-medicalisation. How do we do it in a way that respects those who are suffering from a genuine condition? And I think, thank you so much for being here and taking part in this and making that comment, because that is a tension that we've got to constantly be aware of. And, I hate to say it, but maybe we need a bit more help from the PR people to help us build in that sensitivity whenever we open our mouths about the problem of widening disease definition. So thank you. And just quickly, I totally agree with the comment on measurement. I think at the root of this problem is our unhealthy love affair with measurement and numbers, the tyranny of measurement, the unreliability of numbers. We suffer from that. Medicine suffers from that inherently, and I would love to see a few PhDs on that. The patient information, how do we get this analysis to patients? Very big and good question, thank you, and we can't answer it here, but certainly patient, consumer, citizen involvement in medicine is happening more and more. So your question will be addressed over the coming years, and Bad Pharma and Goldacre is absolutely right. Tragically, we cannot rely on the results of a lot of studies. We know from very good evidence that industry-funded studies are much more likely to find positive results. And one thing that people who are interested can do is seek out systematic reviews of trials. And there's something called the Cochrane collaboration that people may have heard of that systematically reviews trials to try to remove as much as possible a lot of the bias that comes from industry funding. But great question.
No mystery. If you've not had a chance, just Google Cochrane collaboration. It's got a consumer-friendly face as well as one that's focused more on clinicians and researchers, and I use it a lot as a journalist to do searches on things as well. Martin, any thoughts on any of the questions
Only
raised?
a quick one. I mean, medical publishing is a big issue. It's not a area of specialisation for me. But one thing I would say is that it appears that company sponsorship of medical education now is very tightly regulated and very tightly controlled, so that it is legitimately hands-off in terms of the subjects that go on within the medical education sessions and symposia. And it surprises me that the publishing part of that is not as equally well regulated. I mean, maybe it is, but the problem that's being suggested there suggests that the ties are still pretty close. I mean, there's been a lot of work gone into distancing the companies from the education side of things, or at least insisting that they be completely transparent about their involvement in the education side of things. And it sounds from what you say like there needs to be some work done on the publishing side of that as well.
John Giardini.
I just wanted to say that the drug companies aren't the only or even the main bad guys in this, and nobody's done more than Ray to draw attention to the dirty secret of key opinion leaders, that is, we doctors who are on the take from industry, not for personal financial reward but for career advancement. And it's really up to us doctors to show leadership in order to break that nexus between, or the control that the pharmaceutical industry has over medical science.
Well, I think that's where we are ready to finish. I know you've probably got other questions, but the way to propose those is offer them up on the Twitter feed with the hashtag for the festival and keep the conversation going there. No reason to end it right now. In cyberspace, of course. Now, some of you have already worked this out, obviously. If you haven't used this before, what you have to do... So this whole exercise is that each of our speakers have offered a proposition that emerges from their presentation, and then the festival is going to collate this over all the sessions. So what we would like you to do is pick the proposition that you want to kind of emerge from this as a key idea from this session, and then you have to text that big black code, yes, that's right, isn't it, to that text SMS, the mobile number up the top, and the festival will be collating this using this polling device that they're using. So give it a couple of minutes. If you've got mobile phones, text to that number the code of the idea that you'd like to put forward, representative of today's session. Oh, it's good, isn't it? Look at that. I'll give you one more minute. Oh, 32 seconds I'll give you. Rapidly diminishing.
Natasha, there was one other point that Ben Goldacre made in that book, Big Pharma, and he showed how the pharmaceutical companies are infiltrating the consumer groups. And I checked this out, and he's absolutely correct.
Well, Ray's written a lot about that in his work over the years too. Any thoughts on that from the panel?
No, I mean, you're absolutely right. Yeah.
Martin?
Well, one person's infiltration is another person's confluence of interest.
Yeah. And that's it. Well done. So the idea that will emerge is we must place more importance on being good at feelings rather than feeling good. John, you win.
That's what it's all about.
I'm sure that the festival joins me in thanking all of you for the participation in this session, which is no mean feat to achieve in a lecture theatre, so I thank you very much for participating. Can I also thank the sponsors, Vic Health, the Melbourne Ambassadors, I haven't got them all, I've written them down, the City of Melbourne, and also the Club Melbourne Ambassadors program. Now, we'd like to get a message across about buses.
Oh yes, here I come. Hello everyone, you probably heard this in an earlier session. We have a bus that will take people down to the evening session if you're coming along to see Kathy Lett in action. We would ask everyone to come up to the foyer at 4:30 at the information desk, and we'll show you where the bus will be. We'll lead you there.
Mike Flatley, co-director of the festival. John Giardini, Ray Moynihan, Martin Palin, well done. Well done.